Welcome. Today's webinar is Dressings for Success, Wound Care Dressing Selection. We're really excited to have everybody on the line today, and thank you all for participating in today's webinar. We're also pleased to have Kathy O'Toole join us today. She's our primary faculty member on today's Dressing for Success webinar, and she'll be presenting to us information about helping you to select the best wound care dressings for your patients. A big thanks also to our sponsor today, WoundRounds. WoundRounds is the point-of-care wound management and prevention solution, and we thank WoundRounds for making this educational webinar possible. A few notes about today's webinar before we get started. Starters, we want to thank you for joining us and to let you know what you can expect today. We are recording today's webinar, and this is great because for those of your colleagues who can't join us today, this webinar will be available on an archived basis through the WoundRounds website, so others can view this and listen and see this webinar after the fact and on an on-demand basis at the WoundRounds.com website. You'll have an opportunity to ask questions. If you look on your upper right-hand corner of your GoToMeeting dashboard, you'll see that there's a question and answer area where you can type in your questions. So please feel free to do so, and we'll ask Kathy O'Toole to remain after the webinar is over to answer questions. Also, for those of you who pre-registered for this webinar, you should have received a copy of the handouts in advance. We'll again be making handouts available after the webinar, after we've had a chance to wrap up the webinar. And about 24 to 48 hours afterwards, you'll get another email from WoundRounds containing the handouts. So please check your spam filters if you haven't already received this information. But we make every opportunity available to get this great handouts to you. And lastly, our information about contacting the speaker is also available at the end of this webinar. You'll see Kathy O'Toole's contact information, so if you want to contact her outside the webinar, please feel free to do so as well. So again, just as a reminder, if you're joining the webinar late, that handouts are available to registered participants. You would have gotten an email in advance from us with these handouts, or if you didn't get that, we'll also be emailing them to you again after the webinar. And again, one more time, you can ask your questions. We'll take questions at the end of the webinar. Do so by typing your questions into the upper right-hand screen of your GoToMeeting dashboard. So please watch your email for additional webinar information from WoundRounds. I believe this is the 9th webinar that WoundRounds has sponsored, and so please watch your email for future educational opportunities through this company. So at this point, I'd like to do is give you a brief introduction to your faculty members today, and I'm really pleased to introduce you to Kathy O'Toole. Kathy, as you can see, has no shortage of academic credentials following her name, and we're really thrilled to bring such a gifted and talented wound care educator to us today. Kathy is also a clinical consultant for WoundRounds, and in addition to that, she's had a long history of working in both academia and clinical practice and also in industry. So for example, before working for WoundRounds, Kathy was with Smith & Nephew Wound Care Company as a clinical education manager, and prior to that, she also worked in home health care with a leading hospital group here in the Chicagoland area. And before that, she had the opportunity to be an intensive care RN nurse at a leading hospital also here in Chicago. So she's a wound ostomy and continence nurse, WOCN, and she has a long CV featuring her publications and also her healthcare training experience. So we're so pleased to have her today to impart some of her knowledge to us in the area of wound care dressing selection. So I'm very pleased that she's with us today. A couple words about myself. My name is Deborah Kurtz, and I'll be moderating today's webinar. I'm an industry consultant in the area of healthcare with a special interest in long-term care and in wound care. So I'm pleased to be joining you today as well. So at this juncture, what I'd like to do is turn this webinar over to Kathy to discuss what we're going to learn today and then to talk about the great content she's prepared for us in the area of Dressings for Success, Guide to Wound Dressing Selections. So Kathy, please take it away.
Well, thank you, Deb. Thank you for that wonderful introduction. Welcome, everybody. I'm glad that you could join us today. So to begin with, we're going to go through the objectives just really quickly. We're going to discuss the wound characteristics that will influence your dressing selection. go through and select the appropriate dressing based on wound characteristics and the management goals of that particular wound, and then discuss factors that are going to impact healing of the chronic wound as that comes into play as well. Those are the types of wounds that we are discussing. And then we're going to go through kind of briefly some of the mechanisms of action for each wound dressing category. So how do we choose this? Interestingly enough, I was at a seminar last night, and one of the gals that I was sitting with said, you know, there's 3,000 dressings out there. How do we know what to choose? And so that's really the challenge that so many of us face. This is actually just a very small example of how many dressings are out there. So how do we choose? How do we know what we should choose for each particular dressing? So we can choose based on the color of the wound bed. I've often seen it, you know, red, yellow, black. Red being that we've got a nice, healthy, granular bed. Yellow is that we're having some devitalized tissue in there. Black, necrosis. Is the wound bed moist or is it too dry? Can be based on how deep is my wound. Do I have a shallow wound? Is it deep? Do I have undermining? Do I have tunneling? Based on acute wounds, chronic wounds, burn, trauma. And of course, based on signs and symptoms of infection. We're going to go into a little bit more of that in detail later. So I want to make it a little bit easier for you, and then just a little bit of a review of some of the tools that are out there. The principles of measure was actually an acronym that was first in the literature in the 1990s. Actually, we can thank Ms. Baranowski for that. And basically what it says is that we're really looking at minimizing the trauma to the wound bed. We're eliminating dead space. We're assessing and managing the exudate. We're trying to use non-toxic products. We're really removing infection. We're looking at the environmental factors and then the surrounding tissues. And it was a really nice tool. In 2003, Vince Falanga and Dr. Sibold came out with the idea of wound bed preparation. And basically, wound bed preparation says that we really are helpers. We're helping the wound to heal. And so wound bed prep is managing of the wound in order to accelerate the endogenous healing. And then after that, a group of professionals got together. They formed an international panel, and they came up with and published the time principles of wound bed preparation, where the tissue, the T is for tissue, the I inflammation, the M is moisture, and the E is the edges. That later was kind of reworked, and Elizabeth Aiello and others came out with the DIMES principle, which is debriding, again, I for infection, inflammation, M, moisture balance, E for the edges, and then the S is for supportive products. I also mentioned the solutions algorithm here because there are many companies that try to come out with algorithms that really try to help the clinician in utilizing their products in a way of looking at the wound and deciding what products that they would have available to them that would help with this wound healing. So what I'm going to do is I'm very used to the time principles. I find it easy and quick, and so that's what I'm going to discuss here today. I also think that the time principles are important because we really want to get these wounds to heal up, and so we think about how much time is it going to take to heal. So always with that in mind, we want to get these wounds to close up so that we can, you know, have this person more comfortable, less pain, etc. So the time principles of wound bed pressure, the T is for tissue, non-viable or deficient tissue. And so what we're going to do as a treatment modality is that we need to debride that dead tissue in order to restore a healthy wound bed that has the ability to heal. The I for infection or inflammation, what we'll do there is that we want to treat it with some type of antimicrobial activity, and we do, I will talk a little bit more about, you know, cytal versus static, topical versus systemic, etc. The M is actually moisture imbalance. If I've got a dry wound, I need to moisten it. If I've got an excessively moist wound, obviously my first thought would be to absorb that moisture. But actually in the time principle it says, take a step back and look at your bacterial count because you may have excessive moisture related to excessive bacteria. And that's how these stages are interacted with one another. And the E is for the edges of the wound. Are they advancing or non-advancing? Again, those are really keys. Those cells at the edge are really telling us what's going on with the wound bed. So the big picture. The idea of this slide is to really look at not only the whole person, you know, as well as the hole in the person, but it's really to gain an understanding of what the kind of wound, what type of wound you have. So there's really kind of 5 major categories of wounds, if you will: arterial, venous, diabetic, our traumatic wounds, and we can have malignant wounds. So when I'm looking at the big picture, I want to understand, does this wound have a vascular supply? Is this person going to be able to heal? And that brings into account our arterial wounds. Our venous leg ulcers, although we may have a wound that has excessive moisture, we need to understand that the basic pathophysiology behind that wound needs to be addressed in order to accelerate that endogenous healing. With diabetic foot ulcers, obviously this is just such a focus in our literature, is that it's really important to not only deal with the local wound environment with diabetics, is that you really need to address their systemic factors as well. Do I have their blood sugars under control? What other comorbidities are there, etc. I'm also looking at malignancies, is that you'll see in the slide a little bit, is that with palliative care, the goal may not be that these people are going to be able to heal this wound, but certainly wound care is going to be important for them because it does add to comfort measures, odor control, things like that. So again, we do want to apply these principles to that type of wound. So again, the overview of this slide is that I need to understand, why did my person develop this wound? I need to address the factors that are involved with this wound. Do I have a dehisced wound, etc. So the big picture is understanding your patient, understanding everything that comes into play, and then beginning to look at the more local environment. So what do? You assess, assess, assess. That's before your choices. So the wound etiology is important. Do I have an arterial wound, again, just to reiterate, that has poor blood supply? I need to address that in order to understand if my dressing selection is actually going to be able to enhance healing, or if I'm really doing it for protection. So again, the location of the wound: is this a wound that's on the heel? Is it on somebody's ear? Is it the sacral area, etc.? That's going to affect our dressing selection as well. Exudate amount, we'll talk a little bit more about that. Do I have too little moisture? Do I have excessive moisture? What's my dead space situation? Am I filling something, or do I have a very superficial wound? What's the surrounding skin look like? If I have excessive moisture, then I would be concerned that I would have macerated wound edges, and again, those edges would be non-viable. So then again, I want to look at what I'm doing to control that excessive moisture on the wound edges. And again, frequency of dressing change, very important. Oftentimes, in days past, when we used gauze is a very expensive dressing because we find that we have to change that quite often. So frequency of dressing change, sometimes I think it's a really good thing because we're kind of leaving the environment alone. We're allowing the body to heal it. So I don't think it's a bad thing to have dressings that are longer in duration. The care setting is very important. I highlighted, again, palliative care here because in days past, the goal, we all thought the goal was to heal. In this case, it may not be, just to reiterate. And so we really do want to focus in terms of comfort measure, reducing pain for folks in palliative care. I also want to ask myself, what's my product availability? Do I have a pretty healthy formulary, or is there some reason that my products are not available to me, whether I'm in acute care, home care? Am I expecting my patient to be able to do this dressing change? All of those things are really going to come into play, as well as cost and reimbursement. So we're going to start with T for tissue. Non-viable or deficient, again, we've got a defective wound bed, so I want to debride it in order to restore a healthier wound bed that will move into proliferation and wound healing. So the T for tissue, why do I want to debride it? Again, it will enhance my wound assessment. If we've got dead tissue in the wound bed, we're not really able to see the base of the wound, and so we don't really know how deep that wound is. What happens is that the bacteria that's normally found on our body is going to take advantage of this tissue and say, hey, this is great. I'm going to have lunch, dinner, snacks, and everything else in between, and so the bacteria are going to overgrow. So it's a real advantage to remove that dead tissue, not only for wound assessment, but I'm also reducing the potential for infection. And also, by my addressing this and debriding this wound, I'm actually moving this wound out of inflammation and out of the stage where the phagocytic cells are coming in to help debride that, and moving it into proliferation. And in that way, I'm really helping the wound to progress. What am I debriding? I'm debriding dead tissue. I'm debriding non-viable tissue. I just make it simple and say slough is moist, yellow, thin, stringy, but it's basically moist dead tissue. necrotic tissue is dried out, it's hardened, it's thickened. Either way, this is non-viable tissue, and as a barrier to healing, needs to be removed. Now, the methods for debridement, there's a variety of them, and what you need to consider when you're choosing which method you want to use is what's the wound characteristic. So surgical, it can be very quick, but again, you've got to take into consideration the setting that you're in. Most often, surgical would be done with a larger wound that has a heavy burden of necrotic tissue. Autolytic is a slower process, less aggressive, but it is a natural process. And so what we want to do is that we really want to kind of enhance that normal body process. Enzymatic debridement, in years past, when I was out there were collagenate santol, and there was also papinurea. The papinureas are no longer on the market, so what we have for enzymatic debridement is collagenates. And just so that you understand the terminology, when you see ASE after a word, that is an enzyme that is going to reduce the word in front of it. So in this case, the enzymatic debrider is going to reduce or break the bonds with the collagen. Mechanical, that's our wet to dry dressing, that's our irrigation, that's our hydrotherapy. Wet to dry can be considered painful, it's also very expensive. And lastly, I would say the biologicals. Now that takes into consideration the maggot therapy. And again, what I want to consider here is who is my person? You know, who is my patient? What setting am I in? What level of aggressiveness do I want to use? You can mix these methods. So for example, you could choose to have a surgical debridement followed by enzymatic debridement. What care setting am I in? What is my time frame? How quickly do I want to get this debrided? Is there a risk for infection? Again, thinking about the comorbidities for each one of my patients. If I've got a highly compromised patient, then I probably want something a little bit more aggressive to quickly reduce that bioburden and that non-viable tissue. And again, the skill of clinician, as Deb said, we're in the Chicagoland area. There are varieties in the states that allow nurses to debride wounds, so obviously the skill of the clinician is an important consideration. Some people are allowed to do that. Here in Illinois, we're not. Obviously, cost of therapy, pain management is going to be really extremely important. And so again, multiple methods. Don't be afraid to mix these together. So my debriding options, you can see these wounds here. The first picture on the left is when a film has been applied to the wound bed. And you can see that kind of creamy looking exudate. And basically what the films are going to do is they're going to help trap the moisture. So had this wound started out with some dry necrotic tissue, I'm applying a film over there that will allow the tissue to breathe somewhat, but however, it's going to trap some of that moisture, and so I begin to break down that dead tissue. The normal cells, the phagocytic cells, are allowed to come in there and start to degrade it. People get concerned when they remove these films because they look at that creamy exudate and think, oh my goodness, I have an infection. That's really not so. That is a normal appearance of the dead tissue as it's becoming liquefied and degraded. Hydrocolloids are actually a nice dressing. One of the considerations with hydrocolloids is that although they will trap moisture and provide that moist environment, they don't really allow for evaporation of any of that moisture. And so oftentimes the consideration there is that we have to look at, am I having so much moisture that I need to be concerned about maceration of my wound edges? Hydrocolloids by nature, once they're applied to the body, they interact with the heat of the body. They stick really well to the body, but then after about 48, 72 hours, the adhesive in that product starts to degrade, and so they will kind of move around a little bit. And you have to consider also that cleaning after a hydrocolloid sometimes will require you to have additional friction to clean the little pieces off. I think we've probably all experienced that. And so again, this is a nice product for debridement, but take into consideration, again, my whole patient. If this is an elderly patient, it may not want to use a hydrocolloid in that area. Hydrogels, basically, we're providing moisture to a dry wound bed. Again, if I've got dry necrotic tissue, a hydrogel would be a really nice option. If I have, for example, a heel that is dried, hard, SI, as long as that's intact, I would want to just protect that. But once my edges have started to break down, then I would want to remove that because the bacteria will kind of set up shop underneath that nice cap and say, hey, this is great, nobody knows we're here. we're doing really well. So you may want to use a hydrogel in areas where you have that dry tissue that you're trying to really moisten to break it down. Mechanical, as I mentioned before, our gauze wet to dry is one of the considerations with mechanical debridement is that you apply it moist, you apply the gauze moist, and then it's going to dry out through its exposure to the air. What will happen is that the wound bed will stick to that gauze, and when I remove the gauze, not only is that painful, but I'm also traumatizing the wound bed, and I'm sending that wound bed back into inflammation. And so we really want to prevent that. We'll see later on a slide that one of the problems with these chronic wounds is that they keep circling back into the inflammatory phase, and our goal is to get them out of that inflammatory phase. The enzymes, as I mentioned, is our collagenase. Santal is the product that's out there now. Collagenase is moisture seeking, and so when you place collagenase over non-viable tissue, what it's really going after are the collagen strands that are actually attaching that dead tissue to the wound base. And so oftentimes, depending on the moisture level under a dead tissue, there are times where you can just remove this big piece of dead tissue because the collagen bonds have been broken and it's no longer adhering to that wound bed. Enzymatics are a really nice tool. They can be very gentle. They can be quick. Depends, again, on the setting that you're in. And biological, very big consideration there with our biologicals because, again, of course, these are our maggot therapy, and the big consideration there is how am I going to get rid of those. So big considerations there. So these are just examples. This list for each of the successive slides, the list of these examples of products is by no means comprehensive list. These are some of the names that we may be familiar with, such as Tegaderm, Carafilm, Transseal, Polyskin, Shearsite. Basically, as I said, these transparent films, they're films because they are going to allow moisture to move through them. However, they're going to trap the moisture below. Transparent because we can see through them. This makes them a really nice choice when we're trying to debride that hard, dry eschar because you can see it begin to liquefy. You can see the body begin to reabsorb that exudate, and we end up with a nice, hopefully, red granulation wound bed. Excuse that noise there. So the film precautions is that, again, keep in mind that they're not going to absorb. So if I've got a lot of exudate, just know my films are not going to absorb. The concern is duration of the wound bed. Again, remember, I'm keeping moisture in the wound bed. My purpose is to liquefy hard dead tissue, and so I don't want to cause maceration to those edges. Of great concern is for those of us that are familiar with negative pressure wound therapy is that films can be very difficult to apply, especially to large wounds, and we can get wrinkles in there, and that can cause leakage of the fluids. In negative pressure, we're concerned because then we're pulling atmosphere in, and so we won't have really an occlusive dressing. May not be so much concern with our situation with these wound dressings. Can be traumatic on removal, so the suggestion there is that whenever you're applying an adhesive, whether it's a film or adhesive foam, is that what you want to do is that you want to apply some sort of a skin prep. There's sting, There's no sting, and there's ones that are a little bit stingy. The difference between those is that no stings tend to take a little bit longer to dry, so give it a good 5 minutes. How it works with our removal, so that it's an atraumatic removal of this film, is that when you put down the skin prep, what you're putting down is you're laying down a polymer. And when you remove that adhesive dressing, you're pulling that polymer off as opposed to pulling off that first level of the skin. And that's a big consideration, again, when we're talking about how often am I changing my dressing. If I'm going to be pulling off a film once a day, I'm going to end up stripping that skin, and that would obviously lead to some other problems that we don't want, that will degrade that wound. So also on wound cavity dressings, we wouldn't use a film dressing on its own in a cavity wound. We would need to fill that cavity. We always want to fill that dead space. So as a secondary dressing, we could use a film over dead space. And in fact, that's what's really used in negative pressure wound therapy. And we would not want to apply a film over a wound that we suspect infection because, again, bacteria is looking for a nice, warm, moist, dark environment where they can proliferate and that's really just going to help them kind of grow. So we obviously don't want to do that. We don't want to protect them from the environment. Thank you, Deb. Our hydrocolloids, these are just examples. Probably all of us are familiar with Duoderm. I've got experience with Comfeel, Nuderms, Replicare, Restore, Tegaderm. Again, these were one of the first advanced dressings that came out. They're really terrific. The ostomy world depends on them. And for our purposes in wound care, just know that hydrocolloids will trap that moisture under the dressing, but it's not going to really allow the dressing to breathe, and so that moisture vapor is not going to be removed through it. And so in that way, there is the possibility that we could end up with some maceration. One of the advantages to those is that they do come in different shapes and sizes. An additional precaution with this is that there is a risk of hypergranulation tissue. We all know, and I mentioned this earlier, that these can actually begin to melt down. They're very occlusive, and so when we remove them, yes, we're likely to see a lot of moisture. There's also likely to be a lot of odor, and that can be disconcerting. Movement, particularly in our areas where we see, like in the sacral area, patients are moving in and out of bed. They're, going through just, their movements during the day, whatnot, and they can begin to be dislodged, and that's really not healthy for the tissue underneath. Again, I did mention the maceration of the wound edges. They can be very difficult, again, to remove completely, meaning that I may remove the dressing, but pieces of it may be left behind, and then I'm forced to kind of apply some extra friction there to remove that, and that may be detrimental to our surrounding wound area. And they are not meant for heavily draining wounds. That would be where we would get into more of our foams, hydrocolloids. So our hydrogels, again, our hydrogels, again, not a complete list here. Solocite or Inchicite is actually the sterilized form of that. Curacol is very popular. Many of us have seen that. I've seen Vigilon used quite frequently in radiation burns. Very nice gel there, frequently used in the home care setting, in my experience. Basically, hydrogels, they're coming in tubes. They can be spray bottles. They're in sheets. Impregnated gauze, and again, the goal of the hydrogel is that we are donating moisture to the wound bed. I have a dry wound bed. The cells are not able to migrate from the wound edges across the wound bed to fill it in, and so what I need to do is I need to donate some moisture in order to liquefy that necrotic tissue. Again, the goal is I'm using it here because I want to debride it. I want to help remove that dead tissue. Hydrogel Precautions. Again, the viscosity of the product, there's a lot of water in these products, and so some of them may be thinner and dry out more than others that are thicker. So again, make sure that you always read your packet inserts and the information that your vendors will give you on your product so that you understand the dressing frequency change. Hydrogels will absorb exudate, but that's not their primary purpose. Their primary purpose is they're donating moisture. Again, that consideration, always we need to be concerned about maceration of those wound edges, because those cells at the edge are the ones that are migrating across, filling in that dead space, and if we end up drowning them with too much moisture, then they're not going to be viable. They're not going to be able to do that. Hydrogels will require a secondary dressing as well. And gauze, our good old friend, the gauze. Gauze is probably everywhere in all sizes and shapes. Probably Curlex is on the tip of everybody's tongue. Cling, the gauze sponges, we often use those to be able to, clean a wound. Our 2x2 gauzes, et cetera, So gauze is really a great dressing. It's been around, I want to say, since the beginning of time, but I know that that's not true. But gauze is really a great dressing because it can be used as a wound filler. It can be used as a secondary dressing, a primary dressing. We can use it as here as a mechanical debrider. But keep in mind that, again, there's perhaps a linting issue with gauze, and also the cells in the wound bed are going to kind of grab onto that as a way to migrate. They'll hold onto that scaffolding as a way to migrate, and so when they begin to dry out and we remove that from the wound bed, then yes, I'm causing mechanical debridement, but it can be very traumatizing, and again, sending that wound bed back in an inflammatory process, which we're trying to get out of. So gauze precautions, obviously frequency of dressing change, and this really does kind of talk about cost. So although a gauze dressing may be very inexpensive dressing, you have to think about how many times am I going to change the dressing? Do I have a top dressing that I'll also need to change? In terms of, and this is something that I've found that a lot of us don't think about too often, is what is the cost of disposal? And I know when I worked in home care, our home care agency used to pick up the dressings that were discarded by our home care patients, and I literally would have bags of it. So if you factor in the cost of that, not only is there concern about transmission of infectious, bacteria, but also it's very costly to dispose of that. Again, gauze is really not made to be a highly absorptive dressing. Again, in our context here with the time principle, the T, is that we're going to use it here for mechanical debriding. Okay. Our enzymes. So I mentioned this before, Collagenase is basically going to degrade the collagen. It's made from Clostridium histolyticum. It is moisture-seeking, as I said before, and it's going to degrade those collagen bonds that are keeping that non-viable tissue in the wound bed. A precaution here is that you should not use it with metal ions because it will tend to inactivate that when they get together and do their chemical dance. Mercury and silver will inactivate the collagen. Biologicals. I would say, be very cautious with this. And again, when we talk about looking at the whole person, I actually knew someone that did this, and I had a little bit of an issue with it. Forgive me if you're on the phone, but putting maggots on a psychiatric patient is probably not the thing that you want to do. Just the thought of putting maggots on somebody really kind of can cause them some emotional distress. The thing about them is that they are basically sterilized. They come from California. Basically, biologicals are using living organisms, which is what maggots are, to remove necrotic tissue. The thing about them is that they digest necrotic tissue, and they're really great at it. They're very quick. They kind of enjoy that. That's what they're living for. And they are able to digest MRSA. So there's a distinct advantage that I have seen in my experience, and basically this is, perhaps my limited experience, is that maggot therapy will be used in wound care centers, and so not so often in acute care settings. What I've seen that it was a great concern to the infectious disease folks in a hospital that I was working with was that they had applied maggots to a wound, and when the dressing was discarded, lo and behold, what happened was that our little friends, the maggots, turned into flies, and so they had a fly problem in the hospital. So again, you might be looking, and again, we're talking about dressing specifically, and so we want to say, what is this dressing going to do for my wound? But you have to think about what's it going to do to my patient. How am I going to dispose of it? What's going to happen psychologically in this case? So there's other things to take into consideration when you're choosing your dressings. So the time principles. I, for infection or inflammation. Again, we all have normal bacteria, normal flora on our skin, that when we've got basically a hole in the boat or a break in the skin, is that those organisms begin to overgrow. And so we get an infection or inflammation that interferes with our ability to heal that wound. And so what the time principle says is, I want to look at this wound, assess it for infection, and then take the appropriate steps. The appropriate steps are antimicrobials. So inflammation. Again, skin is the largest organ of the body, and I personally think that sometimes I don't remember often enough that it is an organ. We have to keep it moist in the winter. We have to keep ourselves hydrated. We have to protect it from the sun, et cetera, et cetera. 16% of our body weight is our skin. It helps us not only to protect our insides, which sounds perhaps very mundane, but it really actually helps to control what goes on in our body, the movement of fluids, things like that, vitamin D. It's very dynamic. In terms of wound care, it is our physical barrier. And when we end up having a wound, then we have lost that barrier, and so we've lost a protective mechanism. It's important to understand that when we're using, quote-unquote antimicrobials, topical antimicrobials, is that our skin is slightly acidic, and that's really conducive to preventing an overgrowth of bacteria on us. And so it really kind of helps to keep things in balance. So you probably don't want to just continue to shower day after day after day into something that's going to kill that normal bacteria, because then it kind of sets you up for excessive bacterial growth. So again, the pH of some of our products is going to be an important consideration. We do actually want our normal flora be there, but what happens with the time principles is the normal flora take advantage and they begin to overgrow. So inflammation and infection. I said that if we lost our barrier, we lost our protection, we're exposed to the bacteria that's in the environment, that's on our body, and what happens with those bacterium is that they release endotoxins, again, toxins. So it's going to really degrade that wound bed. There's proteases that they release, and so again, that ASE at the end of the word. So our proteins, which are the building molecules, is that we're having those degraded, and we don't want that. And so when we're in an inflammatory state, when we've got a break in the skin, the bacteria are going to take advantage of that and continue to multiply. The problem is that when they grow to such a level is that we have poor healing or we have no healing whatsoever. And so that's what this time principle is going to address is how do I, as a clinician, address the inflammation or infection that's present in this wound when I've lost my barrier. So again, this is an important slide. So our bodies, we have normal flora. In the wound care world, we can say that all wounds are contaminated. When wounds are contaminated, that means that, yes, the bacteria are replicating, but they're really not really disturbing us. We can manage that, and we're kind of holding our own. When we see colonization, the number of the bacteria have increased in number. However, we can still get wound progression. So in those two, again, we're removing the dead tissue, which will reduce that bioburden. In these cases, we may not need any topical therapy and certainly not systemic. It's when we move past this, down the continuum, where we begin to see local infection, a spreading infection, and a systemic infection. It's that area of this continuum where the bacterial burden has increased to such an extent that I can no longer manage those bacteria. The bacteria are overwhelming the body's natural response to keep them in order, and so now they're competing with the wound for oxygen and nutrients and things like that in order to be able to heal. So this is where we see them as a detriment to healing. We have delayed healing or no healing. So what do we want to do with this bacterial burden? Obviously, we want to assess it. This is an important slide to understand that continuum before we get into the dressing selection. So as nurses, as clinicians, we're used to seeing and identifying the typical signs and symptoms of an infection. So there's fever, malaise, pain, etc., things like that. What they have found in wound care is that, and studies have shown this, is that the secondary signs of infection are the ones that really we can rely on to say, yes, this wound is experiencing these secondary signs and symptoms, and we understand that we have delayed healing because of that. So what we'll see is, yes, delayed healing. We'll see changes in the color of the wound bed. We don't really have that robust granulation tissue. It can be very pale, it can be pink. The granulation tissue is very friable, meaning that it's easily damaged. There can be no granulation tissue at all. We would expect to see abnormal odor, increase the amount of drainage, increased pain at the site, and again, delayed healing. And so we can rely on these symptoms to say, I believe that this wound is critically colonized. I've got delayed wound healing, and so what I want to do about this is I want to move into my topical antimicrobials. So my antimicrobials, again, I caution you that this is not a complete list, and there's a very important discussion that we have to have here, is that when bacteria overgrow, when we think about doing cultures, when they do a culture, what we're looking for is how many bacteria are there. And so a wound is considered critically colonized, which is delayed healing, when it's 10 to the 5th, which means you've got a 1 with 5 zeros after it, which is 100,000 bacteria. What I want to see for one of my antimicrobial, if it's truly going to be a cytal event, meaning that it's killing, is I need to have a log reduction of 3. And so what that means is that I'm going to take 3 zeros away. So I go from 100,000 bacteria and I go down to 100, and that would be more manageable. And so a static event, bacterial static event, is going to be when I'm just stopping the bacteria from interfering. When I have a cytal event, I'm actually killing the bacteria. And so in terms of these products, we know that silver is a known antimicrobial. There's a variety of products on the market, and what I would say is that what you want to do is have a very robust discussion with your vendor and ask them to present you with the scientific data that talks about their product. Silver, yes, it is a known antimicrobial, but sometimes the other elements within the particular product that's being marketed will reduce the efficacy of that silver. And so again, we want to make sure that we're not going to create resistance. There has not been any resistance found with silver products, but again, I just always encourage to go after the science to really look at that. In terms of silver, there was recently a Cochrane review, which is the highest level of research that's out there. And basically, the Cochrane review is a panel that looks at all the randomized controlled studies that are out there. And they say, okay, is this a well-designed study? Are we, in fact, showing what we said that we're going to show? And so the Cochrane review lays some questions out about silver and its efficacy. So again, might be worth reading there, just suggesting to really just kind of look at your products. And again, the important thing here is that we want to have a cytal event, or there is a difference, I should say, between a cytal event, bactericidal event, killing bacteria versus bacteriostatic, where we're just kind of controlling them.
Jeff, do you want to say a few words about PHMB, because we hear it everywhere?
You know what? Thanks very much for bringing it up, Deb. I appreciate that. So silver is important. I should have gone into more detail here. The next slide actually does talk about Cadexomer iodine. Polyhexamethylene biguanide is actually in the AMD gauze. It's a really great product and actually used frequently in negative pressure wound therapy. The difference with PHMB is that unlike silver and the iodines and things of that nature, it's really not donating anything to the wound bed. And so what happens is that as that PHMB, as the exudate is taken up into the dressing that has PHMB in it, those bacteria are not allowed to proliferate in that dressing. So that's a really great question. I appreciate you bringing up that, Deb. So in terms of our dressings, I wanted to bring up iodine because iodine can be very toxic to certain people in certain situations. There's really only one product on the market. It's a Cadexomer, and basically I think the picture here is really helpful to understand how it works. So, you know, the question might be, well, if I'm applying iodine, isn't that toxic? Yes, it's toxic to cells. However, at this level, the 0.9% iodine, it's really not going to be toxic to the good cells. It will reduce MRSA, and the way that this works is that when it goes, when the product is put into a wound bed, it's kind of a monitored release, if you will, is that it's going to absorb. It's made of a starch, and so it's going to absorb that exudate. And as the exudate is absorbed, then there's this sort of swelling, if you will, and then the bonds between, let's say, like the struts of the ball, if you will, actually break and release the iodine. So in that way, as I'm picking up the moisture, and I know I've got excessive moisture because of infection and because of bacteria, and so some of those bonds are broken, it drops out the iodine. So it's really kind of managing how it's going to release that. There is a sustained activity, and again, sustained antimicrobial activity is important for some of these dressings. And in this way, this dressing not only is helpful with my tea for debriding, because it can debride those fluffy wounds, it will absorb that exudate, but it's a really great dressing here for infection and inflammation management. Some considerations for this are obviously because of the iodine. The consideration is that anybody with iodine sensitivity, Hashimoto's thyroiditis, history of Graves' disease, obviously we know that both of these diseases have to do with the thyroid. The thyroid does regulate, there's some iodine molecules in there, and so anything having to do with the thyroid, very cautiously use this, and again, talk to your physician about whether you would want to use this product with anybody with those diseases that have to do with your thyroid. And obviously the goiters are related to these diseases as well. So just in general, some precautions about antimicrobials is that, and we kind of all know now that antimicrobial agents have been overused, and so the CDC has said, you know, we really need to take a step back and not just be prescribing them, you know, ad lib, so to speak. And so we don't want to use agents topically that would be used systemically, such as gentamicin or tautomycin, because what our concern is there is that we will create superbugs and that we will lose the ability for that bacteria to be sensitive to these agents. We also don't want to use agents that are common allergens. They're listed here. This is actually very important to consider. Again, who's my patient? Do I have a patient with a venous leg ulcer? Venous leg ulcers, just because of the disruption related to the pathophysiology in the way the skin is handling and able to sort of filter some of those products, we want to be really careful with venous leg ulcers and applying products that can cause an allergic reaction. And again, I mentioned this earlier, any agents that are cytotoxic, that means not only is it going to kill the bacteria, but it's also going to kill the healthy cells. And if I'm killing my healthy cells, then how is it that I'm going to be able to rebuild my wound bed? So again, use those with caution. The time principle. So we know the T is for tissue non-viable. We're debriding it. The infection or inflammation, again, is that cascade of events when we've got critically colonized wound, whether it's local or systemic. If we've got systemic, then we probably need both systemic antibiotics and local treatment. The M is for moisture imbalance. Is my wound too dry, or do I have excessive fluid? If I have excessive fluid, again, take a step back and look at the eye, because if I've got excessive bacteria, I likely will have excessive moisture. Okay? Moist wound healing. Our friend Dr. George Winter actually published in Nature in 1960 that a moist wound environment is really essential to healing. And he was doing some work on pigs, and he found that when the wounds were allowed to scab over, there actually was much longer time to healing. And so a moist wound bed is really what it's all about. Chronic wound fluid, very different. Again, we're going to wick away this extra moisture. Chronic wound fluid, again, it's keeping me in that inflammatory phase. So I've got those pro-inflammatory cells in there, matrix metalloproteinases. I've got the cells that are breaking down the protein. I've got cells that say, I don't feel like working anymore. I don't have my growth factors. So there's a lot of dysfunction in the chronic wound fluid, and that's why we want to wick it away, but we don't want to remove all of it. So dressing selections. Basically, it's really simple. If I've got a dry wound, you want to add moisture. If I've got excessive exudate, look at the eye, but also wick that away. I don't want to trap moisture in infected wounds. Obviously, always protect my peri-wound. And actually, I'm providing protection to the wound from the wound environment. Some of the important things about these dressings that will absorb is the contact layer. So these layers sometimes will have other products in them that will help maintain a moist wound environment. Often they also do need a secondary dressing, but again, contact layers, you don't want them to dry out as well because, again, they're going to adhere then to the wound bed and cause trauma when they're removed. So some precautions, I think I just said these. So the contact layer, obviously, you don't want them to dry out. These are really great products. They're very soothing, sometimes in radiation burns or burns in general. Sometimes, you think of a dressing as a sandwich, and so sometimes we're using multiple dressings together. So the contact layer is going to be important. What we're looking for is a dressing that's really not going to adhere to the wound bed. And so this slide just really kind of is a very big, broad overview of how much exudate am I going to be able to manage with these dressings. Obviously, films are not going to manage moisture. Hydrogels are donating. Hydrocolloids are kind of donating. They're not going to absorb. When I get into my alginates and my foams and my specialty dressings, that's where I'm really starting to absorb the moisture. So I'm going to try to, in these next couple of slides, we're going to kind of bring it all together. So this is a diabetic wound. It's an arterial wound, so I've got a small amount of drainage, if at all. So what I want to use my products to moisten it is I want to provide moisture, the hydrogel, the films, the hydrocolloids, and the thin foams. Managing an exudate with this is that, again, venous leg ulcer. So take into consideration what's my basic pathophys is that I have to, I want to normalize the vasculature of the limb, and so I want to enhance circulation to remove some of that edema, and so I'm going to apply compression here. But from a local wound environment, what I want to do is I want to absorb some of this moisture. So I can use my alginates, my foam, my specialty dressings, and I can use these under compression. So examples of foam, there's so many out there. Where we begin, different sizes, shapes, colors, Aquacel, Alevin, et cetera, et cetera. There's just a variety of them. But our foams basically are made of various size cells. They're going to allow those open pores to be filled with fluid, and that way they're wicking that moisture up from the wound bed. The contact layer hopefully will be able to maintain that moist wound environment. Some of the precautions, obviously, we don't, again, want to dry out the wound bed. We don't want these dressings to stick to the wound bed because, again, as I said earlier, we're going to cause trauma when we remove it. And so some of these, if they're non-adhesive, will require a secondary dressing. And one thing I want to point out is that I think you may have observed that I'm starting to say the same thing over and over. And I think in that way, for me anyways, the time principle helps to make things easier. Is it my T, my I, or my M? The basic thing is I want a moist wound bed. And I don't want things to stick to the wound bed to cause trauma and stay in inflammation. My alginates, these are basically made from brown seaweed. They're dyed. They're in ropes. They're in sheets. Basically, they're highly absorptive. They're nice to fill dead space. They do require a secondary dressing. Sometimes there is other, silver in them, things like that. Again, the caution again is, am I going to macerate my wound edges? My hydrofiber Aquacel is the only hydrofiber out there. It's often put in the category of an alginate. However, it is actually a man-made fiber, probably used in the same way. There are some studies that suggest it might be a little more highly absorptive than an alginate is. It's a really nice product. So Aquacel is our only hydrofiber, not made from seaweed, but made from a fiber. The precautions are, again, maceration, secondary dressing. You don't want to use this with oil-based products such as petroleum jelly, etc., things like that, because it's not going to be able to then wick away that extra exudate. So this is a wound pressure ulcer. Started out with large amount of non-viable tissue, and so what do I want to do? I want to debride it. I can use my film. If I've got a lot of exudate with that film, then am I protecting my wound edges? Do I have a cavity? Well, I need to fill that in. With the high bacterial burden here, yes, I have to be concerned about what kind of antimicrobials I'm using. So a wound like this, first choice would be, maybe we want surgical debridement followed by enzymatic. Let's kill that bacteria by killing the dead tissue and move on to healing this wound by creating a nice moist wound environment. And then just really quickly, the time principles of wound bed prep with edges, the edges of the wound bed. So very basic question here. If the edges are migrating across the wound bed, if we've got a healthy wound bed and the cells are able to migrate across, then I'll have wound contraction. If they're not, I've got an unhealthy wound bed, and I have to ask myself why. Why aren't these cells migrating? Is it my T, my I, or my M? And again, some products here, collagen is going to help build up that wound, provide the collagen that's needed to start to build that structure, and these are just some of the products that are available. And again, look at the product inserts. Some of them have more to do with MMPs than others. You have to use caution with these when it's made with bovine materials and sensitivities, obviously. In advanced dressings, these are going to be our skin substitutes, our growth factors, extracellular matrix. There's other miscellaneous products that will help with migrating those wounds, etc. Ultrazeal is nice with pylonal cyst, etc. Kind of like a flaky hydrogel in a way. But a lot of advanced therapies as well as some adjunctive therapies, which would be HBO, mist therapy, electrical stim. Obviously, negative wound pressure therapy can address the T, the I, the M, and the E because we do have that wound contraction. So just to review, we did go through discussing the wound characteristics. We did talk about selecting the appropriate dressings for the characteristics of the wound and the overarching management goals, knowing my etiology of the wound and who is my patient, what are their comorbidities. We know that chronic wound fluid is different than other fluids, and so we've got to take that into consideration. And we talked about the different dressing categories. Here are some of the references.
So Kathy, I wanted to thank you for a great webinar today. We covered a lot of material in a rather short amount of time. So for those of you who joined the call late, we will be sending you handouts following today's webinar. You'll receive a PDF of the slides that Kathy covered today. You'll also be receiving an email with how to rewatch this webinar on demand. It'll be available at the WoundRounds woundrounds.com website for you or your colleagues to take a look at later. So a big thanks to WoundRounds for making this webinar available today and for inviting Kathy O'Toole to join us and for doing such an excellent job, Kath. It's really great to hear somebody who's got a lot of experience caring for wounds in the trenches and also who is an expert in helping to adults learn. So we really appreciate what you've brought to the table for us today. And a special bonus, for those of you in your facilities who are responsible for the learning and teaching of others, Kathy has agreed to make available a post-test and an answer key, which we will be sending to you along with your copy of the handouts. And this is really great if you'll be using this webinar within your facility to help advance the learning of others. You can actually give them a post-test and then grade their post-test with the materials that you'll be receiving from Kathy. So watch your email for information about that. Also keep your eyes peeled on your email for more webinar opportunities from our sponsor, WoundRounds. At this juncture, we've got time for a couple questions, and Kathy has agreed to stay on and answer these for us. So what I'd like to do is ask the first question for you today, which is, it came in from one of our participants about once a wound is cleanly debrided, is it desirable to close the wound with a primary dressing that requires minimal dressing changes and keeps the wound moist but not wet? I'm wondering how you'd respond to that, Kath.
Well, thank you for that question. I think it's a very well-stated question, and very simply I would say yes. The goal is obviously to debride that dead tissue. And when you think about debriding, what we're doing is we're really trying to kind of help the body. Again, looking at the whole person is why do they have that wound to begin with? That yes, they can send in cells that would remove that dead tissue, but if I can remove that dead tissue rather quickly, then we move into proliferation. So yes, once the wound is debrided, then you want to really enhance the body's normal mechanism to move the cells in that are going to be the building cells. And I kind of think of it, we're having a lot of storms here, think about it as, you know, the hurricane, the tornado, the tsunami comes through, and so we've got a lot of debris in the field. We need to clean that out. That's inflammation. That's that debridement. And then we want to maintain that moist wound environment. We want to maintain the surface area so that we can build new structures. So yes, the short answer is yes, that's exactly what you want to do.
Kath, I think I have time for another question. Does the time principle work for only certain types of wounds?
No. One of the things I'd like to point out is that the wounds that we're really talking about are chronic wounds. And so if you think back to wounds that close by primary intention, you go to surgery, we're going to cut you open, we're going to close you. But in our wounds, these are wounds that there is a particular deficit. They're going to heal by scar formation. What's necessary for that is a granular wound bed. And so anytime that you have an open wound that for whatever reason is kept open, even if it's a delayed primary closure, you can utilize the time principle for that.
And we have time for one last question today. A question has come up about the use of Hydrogel. And I myself am not familiar with this. I'm going to ask Kath if she's familiar with it.
I've not heard the term Hydrogel, but I'm wondering, it makes me think of something that's very wet. So again, if you think about a dry wound, I'm not sure what product it would be, but it sounds like it would donate moisture. The correct term may be a hydrogel, hydro meaning water, in a gel form. And so I'm not quite sure what Hydrogel is.
I'm sorry that we've run out of time today, but want to encourage all of our participants today to feel free to reach out to Kathy O'Toole. And please watch your email for upcoming announcements from WoundRounds. Your handouts, your post-test and answer key will be on their way, as well will be additional educational opportunities made available through our sponsor, WoundRounds. So I'm Deb Kurtz on behalf of WoundRounds, and a big thanks to Kathy O'Toole. Thanks for joining us today.